Chapter 47 Lower GI Problems. Your abdominal landmarks are generally divided up into four quadrants. The upper right, containing the liver and gallbladder, the upper left, containing the spleen and pancreas, the lower right quadrant, containing that appendix, where if you're ever on NCLEX, ATI, and the patient suddenly has lower right quadrant pain, it's appendix, and the left lower quadrant, containing the sigmoid colon. Let's start with diarrhea. By its definition, diarrhea is the passage of 3 or more loose stools per day. In acute, it is 14 days or less, persistent, lasting more than 14 days, and chronic, more than 30 days. Carefully monitor them for hypovolemia and fluid status, as keep in mind this can also cause metabolic acidosis as well. For diagnostic studies, we'd start with stool cultures, looking for blood, mucus, white blood cells, and other infectious organisms. We could also be looking at blood cultures, identifying sepsis, or if they're immunocompromised, white blood cells, anemia from the iron and folate deficiencies, BUN, creatinine, electrolytes, pH, osmolality, checking the stool for fat and protein, and other GI hormones. As soon as you see diarrhea in the clinical setting, immediately be thinking C. diff. This is a healthcare-associated infection. Patients at risk are those receiving antimicrobial, chemotherapy, gastric acid suppressing, or immunosuppressive agents. C. diff spores can survive for up to 70 days, and this is going to be a strict infection control precautions. Often, unfortunately, a lot of the patients you see with C. diff are something us as providers have done. These patients have normal biota within their GI tract, and when that patient's on antibiotics, it's taking out the pathogen we're targeting, but it's also damaging the normal biota within their GI, and that leaves it wide open for Clostridium difficile to proliferate. For NCLEX, it's always going to be hand washing with soap and water, as that alcohol-based foam does not kill C. diff. Keep in mind, these patients are going to be on strict contact precautions as well, so we're not spreading it around the hospital. Let's move on to fecal incontinence. We should start trying with a bowel training program. The best time to schedule elimination is 30 minutes after breakfast. If ineffective, we can administer drugs like Biscodile, glycerin suppositories, or small enemas to stimulate anorectal reflex until a pattern is established. We can also try methods such as digital stimulation or tap water irrigation. On the opposite side of the spectrum, we have constipation. Our risk factors for constipation include a low-fiber diet, decreased physical activity, opioids and narcotics, ignoring the urge to defecate, including prolonged retention, desensitizing the muscles and mucosa, and as the stool dries, the water is absorbed, making it harder to expel. Your first intervention is going to be fluid, fiber, and exercise. If those are ineffective, we can then move on to things like laxatives, enemas, peripherally acting opioid receptor antagonists, biofeedback, and unfortunately it can even move on to colostomies, ileostomies, and continent fecal diversions. Acute abdominal pain and laparotomy. This is characterized by an acute onset of pain, and it requires immediate attention as it can be life-threatening. Causes organ damage leading to inflammation, infection, obstruction, bleeding, and even perforation. Perforation results in that peritonitis, an infection within that peritoneal cavity of the abdomen. This is going to be characterized by things like distension, fever, and infection. It could also go along with bleeding or obstruction, and the peritonitis resulting in hypovolemic shock. Moving on, let's talk about abdominal trauma. These are injuries that could be a result of either blunt or penetrating trauma. Common areas are liver lacerations, ruptured spleen, mesenteric artery tears, diaphragm rupture, urinary bladder rupture, great vessel tears, renal and pancreas injury, stomach or intestine rupture. Could be blunt trauma in the form of motor vehicle accidents, direct blows and falls, or penetrating, such as with a knife or gunshot. Remember to assess perfusion and bleeding at the site in all penetrating traumas. Your major concerns are going to be shock, such as from bleeding from the solid organs, peritonitis, where those hollow organs, such as your intestines, spill their contents into the abdominal cavity, and abdominal compartment syndrome. This is increased volume that increases abdominal pressure, which leads to decreased ventilation, respiratory failure, decreased cardiac output, venous return, and arterial perfusion or renal failure. Also, remember, avoid Tylenol with any sign of a liver injury. In the case of chronic abdominal pain, our common causes are going to be irritable bowel syndrome, chronic pancreatitis, hepatitis, pelvic inflammatory disease, adhesions, and vascular insufficiency. The patient should be in PO for 8 to 12 hours prior to a gallbladder ultrasound and monitor for perforation after all endoscopic procedures. Because again, they're putting a camera down in that patient's GI tract. And did the doc accidentally tear something is going to be a major concern. Next, let's talk about IBS, irritable bowel syndrome. IBS is a chronic abdominal pain or discomfort and an alteration of bowel patterns. It could be diarrhea or constipation. Either may predominate or alternate. It has no known organic cause. Psychological stressors could play a role, and also things like GI infections, adverse reactions to food, dietary intolerance, and it's characterized by abdominal pain for 3 months. And this is that time frame that distinguishes IBS. One common dietary intolerance is celiac disease. This seems to have been more and more common in the last decade or two. And this is going to be a reaction to wheats, glutens. The diagnosis of IBS is based solely on symptoms. There is a Rome 4 criteria that defines the presence of abdominal pain and or discomfort for at least 1 day a week for 3 months, and associated with 2 or more of the following defecation changes, such as a change in stool frequency or a change in stool form. Appendicitis. Appendicitis is an inflammation of the appendix. It's the most common emergent abdominal surgery, and it's going to originate in that lower right quadrant, also called McBurney's point. And it has a common age of 10 to 30 years. And unfortunately, there's an obstruction within that appendix, resulting in distension, venous engorgement, the accumulation of mucus and bacteria, leading to gangrene, perforation, and peritonitis. Here we have a diagram of that inflamed, swollen appendix. And one NCLEX question you'll see come up a lot, something to keep in mind, is your patient arrives to the ER, they've got lower right quadrant pain, and it goes away. In that case, that is a medical emergency because that appendix is now ruptured, and the pain is gone, and the patient's now going to be developing sepsis. It manifests initially as a dull periumbilical pain, anorexia, nausea, vomiting, and that persistent pain at the right lower quadrant. It could also go along with fever, localized tenderness, rigidity, rebound tenderness, muscle guarding. May also have increased pain with coughing, sneezing, or deep breath. Peritonitis. Peritonitis is that inflammation of the peritoneum. It's primarily caused by blood-borne organisms, could also be secondary to a perforation of the organs that spill their contents into that cavity. The pathophysiology is initially a chemical peritonitis that progresses to bacterial, causing fluid shifts and adhesions. Abdominal pain is going to be your most common manifestation, with that universal sign being tenderness over the involved area. They may also have rebound tenderness, meaning they have pain when pressure is relieved from it. Other complications include hypovolemic shock, sepsis, intra-abdominal abscesses, paralytic ileus, and ARDS. During that nursing assessment, we're going to listen to bowel sounds and also assess for distension, guarding, nausea, fever, and hypovolemic shock. Gastroenteritis. This is an inflammation of the mucosa of the stomach and small intestine. It features sudden diarrhea, nausea, vomiting, fever, and abdominal cramping, commonly caused by foodborne illnesses such as norovirus. Diagnosed with lab tests specifically for that virus, and the treatment may be self-limiting, oral or IV fluids, and others treatments similar to diarrhea. Inflammatory bowel disease. This is a chronic inflammation of the GI tract, characterized by periods of remission and are interspersed with periods of exacerbation. Classifications include ulcerative colitis of the colon and Crohn's disease, which is anywhere in the GI tract, mouth to anus. It begins in the teens or early adulthood, and secondary peak in the 60s. Particularly at risk is family history, as this does seem to run in families. Crohn's disease. This is, again, mouth to anus, the distal ileum, and proximal colon. And it forms these skip lesions, which is normal tissue between areas of inflammation. All layers of the bowel wall can be affected, and also have a cobblestone appearance from the deep ulcerations. Strictures could form along with bowel obstructions. Also, a major danger is going to be leaks, as abscesses form within the peritoneal cavity. The fistulas are common. Ulcerative colitis, again, involves the colon, starts in the rectum, and spreads to the cecum. And it affects that mucosal layer. Diarrhea and electrolyte loss, as the body can't absorb them through that inflamed tissue. You're also going to see protein loss in the stool, and pseudopolyps begin to form. These are tongue-like projections into the bowel. And your hallmark sign of ulcerative colitis are going to be loose, watery, bloody, mucousy stools. Here we've got a picture on the right showing that ulcerative colitis and the effect it's having on that colon. It's going to be characterized by diarrhea, bloody diarrhea, mild with fewer than 4 stools a day, moderate up to 10 of these stools a day, coinciding with malaise, anemia, and anorexia, and in severe cases, 10 to 20 of these bloody mucousy stools, also going along with anemia, tachycardia, and dehydration, as water is lost and the patient begins to develop abdominal pain, fever, and fatigue. Does have a second peak in the 60s, so inflammatory bowel disease is very common amongst the elderly. But unfortunately, this also makes diagnosis more challenging. We can see drug therapies and surgeries considered, though these have an increased risk of adverse events, hospitalizations, and mortality, as well as the elderly also having a higher risk for infection and cancer. More common is anemia, malnutrition, and volume depletion. Let's talk about intestinal obstruction. There are different types of intestinal obstruction. The first will be mechanical or physical obstructions, such as a small bowel obstruction, caused by surgical adhesions, hernias, cancer, strictures from Crohn's disease, or lower bowel obstruction, colorectal cancers, diverticular disease, and other adhesions, ischemia, or Crohn's. They may also take the form of non-mechanical, which are reduced or absent peristalsis due to altered neuromuscular parasympathetic innervations. The 4 hallmark manifestations are abdominal pain, nausea and vomiting, distension, and constipation. The order and degree depend on the cause, location, and type of obstruction. Polyps. Colonic polyps arise from the mucosal surface and project into the lumen. We have a diagram there on the right. There can be different types based on their shape. A sessile is a flat, broad-based, and attached to the wall, whereas a pedunculated is attached to the wall by a thin stalk, such as our figure right there on the right. Sessiles, when small, and pedunculated as enlarged, and they increase in incidence with age, especially within the proximal colon. Common signs are rectal or occult bleeding, and may be asymptomatic. Remember that increased risk for colon cancer does go along with the polyps. While polyps themselves are not cancerous, they can develop into cancer. And patients with this condition are going to need to receive yearly colonoscopies. Colorectal cancer. There is no single risk factor. The highest risk being the first-degree relatives with colorectal cancer and people with inflammatory bowel disease. That family history or familial adenomatous polyps have a hereditary form. They run in families. They also have other risk factors such as obesity, smoking, more than 7 servings of red meat a week, and more than 4 alcoholic drinks a week. Symptoms often do not appear until the disease is in advanced stages. Common would be things like iron deficiency anemia, rectal bleeding, abdominal pain, and change in bowel habits. In the early stages, there could be none or non-specific, such as fatigue or weight loss, though in the advanced stages you begin to develop abdominal tenderness, a palpable mass, hepatomegaly, and even ascites. Bowel resection and ostomy surgeries. An ostomy is a surgically created opening or stoma on the abdomen for fecal elimination. Named for its location, such as in the ileum, it's an ileostomy. The colon, or a colostomy, they may be temporary or permanent. Always remember to assess that stoma as well, as it should be moist, pink, beefy red, look like fresh hamburger. If you start seeing dry, dark, or dusky stoma, that's a sign of ischemia and it's a medical emergency. What's happened was that intestine is very vascular, And the danger is when they create that artificial opening, they've actually kinked it. So if it falls the wrong way and kinks itself, that end of that stoma is now losing perfusion, where it's going to turn dry, dark, dusky, and we need to get them to surgery or something to correct this immediately. The body needs so much intestine to live, and especially by the point that they're getting ostomies, we're losing it steadily. Here in figure 42-10, we have the different forms of ostomies. Generally, they're, again, named for where they occur, what part of the intestine they come. Also, I included this at the bottom, as this was an NCLEX question. They say a wound ostomy specialist will mark the desired ostomy site preoperatively. My experience, I worked in intestinal transplant at the Cleveland Clinic, and I kind of got a feeling the surgeon's going to pick the spot that he thinks is best. In the case of a double-barreled stoma, this would be a bowel divided into two stomas, created both proximal and distal ends through the abdominal wall. The proximal is for fecal diversion, while the distal, the second fistula, is for mucus drainage. When caring for a patient with colostomy, especially post-operative, we're going to carefully record the volume, color, and consistency of the drainage. Excess gas is common for 2 weeks, though this is temporary. When assessing ileostomy function, 24 to 488 hours minimal. The peristalsis should return with 1,500 to 1,800 milliliters of output per day. We also want to carefully monitor the patient for fluid and electrolyte balance, as some ostomies can be extremely hyperactive. The bowel does adapt and increases its absorption as the body adjusts to having this. Diverticulosis and diverticulitis. Diverticula are saccular dilations or outpoachings on the mucosa of the colon and are very common, especially in the elderly. By definition, diverticulosis is multiple non-inflamed diverticula, while diverticulitis is one or more inflamed diverticula. Complications include perforations, abscesses, fistula, and bleeding. This can also be a very painful condition for the patient. In the case of diverticulosis, most patients are asymptomatic, characterized by abdominal pain, bloating, flatulence, changes in bowel habits, serious bleeding, and diverticulitis. In the case of diverticulitis, this is acute pain in that lower left quadrant, distension, decreased or absent bowel sounds, nausea, vomiting, systemic symptoms of infection. Older adults tend to be afebrile while having normal white blood cells, though with possible abdominal tenderness. Other complications include erosion of the bowel wall and perforations and abscesses, leading to peritonitis. Best treatment for this is prevention, in the case of a high-fiber diet with decreased fat and red meat. Also, increasing physical activity. In the case of acute diverticulitis, your goal is to allow the bowel to rest and reduce inflammation. The patient should be on clear liquids, bed rest, and receive analgesia for the pain. With severe symptoms, they could have a systemic infection and comorbidities such as hospitalization, keeping the patient in PO, on bed rest, IV fluids and antibiotics, and observing for signs of abscesses, bleeding, and peritonitis. From there, we can advance the patient's diet as needed. Let's talk hernias. A hernia is a protrusion of intestine through an opening or weakened area of the cavity wall. Most occur in the abdomen and also occur more in men than women. Some are reducible, meaning they're easily returned to the abdominal cavity. A major danger, though, is some could become strangulated, meaning that shifting, moving has resulted in a kink and a loss of blood supply. They could also result in intestinal obstruction, gangrene, and necrosis. Any patient with nausea and vomiting going along with a hernia indicates strangulation and is a medical emergency. Malabsorption syndromes. Malabsorption syndrome is the impaired absorption of fats, carbohydrates, proteins, minerals, and vitamins. Most common causes include things like lactose intolerance. It could also be related to inflammatory bowel disease, celiac disease, tropical sprue, or cystic fibrosis. And some common signs can be found in your textbook on table 42-32. And these would include things like weight loss, diarrhea, and steatorrhea. We touched on celiac disease earlier. It is an autoimmune disease that damages the small intestines and is triggered by gluten. Things like wheat, barley, and rye. and also could be associated with other comorbidities such as rheumatoid arthritis, type 1 diabetes, and thyroid disease. I also included this chart below me with foods with hidden gluten, and this is areas that both ATI and NCLEX likes to hit on, because there may be things that contain gluten that you wouldn't think. Soy sauce, pickles, instant coffee. Normal coffee is fine, instant coffee is not. Sushis, dark chocolate, ice cream. Chocolate malts are another one I see come up a lot. Because who eats chocolate malts anymore? This isn't the 1950s. But that malt does contain gluten. Short bowel syndrome. In this case, there is reduced surface area within the small intestine that results in inadequate absorption of nutrients. Causes damage to the intestinal mucosa, congenital defects, surgical removal of 70 to 75% of the small intestine. Adaptive changes may occur depending on the remaining intestinal structures. Anorectal problems. We all know what hemorrhoids are. These are dilated hemorrhoidal veins. Internally, they occur above the internal sphincter, and externally, they occur outside the external sphincter. They are characterized by increased anal pressure and weakened connective tissue that results in downward displacement, which results in dilation of these veins. Risk factors include things like pregnancy, constipation, straining, diarrhea, heavy lifting, prolonged standing and sitting, obesity, and ascites. Anal fissures. These are skin ulcers or cracks in the lining of the anal wall, caused by things like trauma from hard stool, anal traumas, local infections, especially from STDs, and inflammation. High pressure and poor blood supply result in ischemia, which results in an ulceration of that wall. The symptoms include severe anal pain, especially with defecation and direct pressure, diagnosed with a direct examination, and treated with fluid, fiber, sitz bath, topical analgesia, stool softeners, and, in extreme cases, surgery. An anorectal abscess. This is a perianal collection of pus due to obstruction of anal glands that result in infection, which results in abscesses. Manifested by a local severe pain and swelling, foul-smelling drainage, tenderness, fever, sepsis. Diagnosed with a rectal examination. The treatment is a surgical drainage, antibiotics, and the nursing care is going to be moist heat, positioning, low fiber diet, education involving the wound care, the perianal hygiene. And I've got a great picture of an anorectal abscess here on the next slide. I'm kidding, I'm not putting pictures of these in here. An anal fistula. This is an abnormal tunnel from the anus or rectum to the skin, vagina, or buttocks. It proceeds or due to an abscess or complication from Crohn's disease. And again, it's going to have that bloody, purulent, fecal drainage. The treatment's going to be surgery, a fistulotomy, and in some cases, ligation with the intrasphincteric fistula tract, rectal flaps, plugs, fibrin glue injections. Your big takeaway here is that all perianal wounds are at high risk for infection. We want to closely assess these patients and do everything we can to keep it as clean as possible. A pilonidal sinus. This is a small tract under the skin between the buttocks and the sacrococcygeal area. It is congenital in origin and is lined with epithelium and hair. Irritation may cause a cyst or an abscess, resulting in pain and swelling. Treatment of the abscess includes irrigation and drainage. For us as nursing, that's going to be warm, moist heat, positioning, and providing education on avoiding dressing contamination and straining. And finally, I just got a little wrap-up slide here for your major takeaways from this one. Your different quadrants, which organs are within those quadrants, as well as some teaching, such as yearly screenings for all high-risk colon cancer patients, especially those with polyps, monitoring for perforation after all endoscopies. A patient should be in PO for 8 to 12 hours before most GI imaging studies. The definition of IBS, which is abdominal pain for 3 months or longer, and how to treat with C. diff. Always wash your hands with soap and water. That comes up in NCLEX and ATI so much. But anyway, that's all I've got in this chapter. I'll see you in the next slides.